So I just want to tell you a little bit about where we've been, how we've been moving on from really what Sally's been saying about how a momentum's really been developing. So very briefly about how, a little bit about who, what's the list of that really, what we've been trying to do, what we put in and what we've taken, or what we've had outside the what we call mental health prevention. And I think you might want to discuss that. What does this all mean? What can you actually do about it when you've got a plan in place? And particularly important about how we manage change. I may jump a few slides, but we'll talk a little bit about one or two of the things after in the setup for the workshops after the break. And I don't want to keep you too far away from your lunch as we're getting fairly close to it. So we've had time for change. We've had this anti-stigma campaign, which really brought a lot of people together. Around about October last year, it was really catalysing what was happening. That was last week's Park Run, so it's ongoing and it's developing. I think the other thing that brought all this home to us as well in services, when we were doing work on pathways to recovery, this was work with Rethink and the academic health science networks locally. And as we worked on trying to work out, with psychosis particularly, what happens to somebody, or what should happen to somebody, as they move through their life pathway, or episode pathway with psychosis. And we're really defining things about screening, assessment, discussion, care planning, what does that involve, when do they get it, what's the timing for that. But right at the front, there was always this bit about prevention and early detection. And it was pretty empty, really, in terms of what we were thinking about doing. And then, having been a trustee with the foundation for 3 or 4 years, I think now, what was certainly emerging in the foundation was about prevention. Prevention becoming increasingly a direction which work was being developed, and some really interesting work about what might work. Because again, this issue about prevention can be talked about in so many ways, it can seem so broad and so nebulous and so ill-defined. Definitions beginning to emerge. So we then started to think about how do we take this momentum, who do we involve, and this came together really quite very much from the anti-stigma group. That there were really a lot of people who were very interested in prevention. And we started to think about the concept of a mentally healthy community. And again, as we were talking, I think one of the development groups in the foundation about all this work, what about a pilot? What about piloting it somewhere and actually seeing what a local community would do with this information? And this was the time that the anti-stigma work was really taking off. And so we put together a group, invited people who came, and then brought others. And it was the people from right across the system, I think, including children's service. I think we've still got to engage more in children's service. I know someone's coming from camp, but what do you need? So he's really been trying to make sure that that area, which is so clearly very important, is considered. And there was also Head Start, which is a program that's been piloting in Southampton for children, which is now beginning to sort of try to extend that. And that again seemed really quite an interesting area where work is coming in. And then people here who know more about this than me, I think. So it's a very interesting area and very relevant to the plans. Voluntary sector, IAPT, substance use agencies, homeless agencies, and substance use, not so much carers yet, but I think that's an area we need to be thinking about. Universities as well, from the University of Southampton, which is part of my role as part in Southern Health, and also as a community psychiatrist, and I think that's also, from my point of view, really important. Community psychiatry seems to have disappeared in psychiatry. I don't know where it's gone, but we really do need to put it back. So 10, 20 years ago, we were talking very much more about extending out into the community, and I think we've entrenched a bit. Mental Health Foundation, and then of course the Mental Health Task Force were coming out. So the who was that group? Many others as well that were involved or could be involved. What were we trying to do? Well, we were thinking about what do we do? How do we take this forward? And the Mental Health Foundation, Isabella produced this map, table, that I think we're thinking about it as a map, which I think seeing this suddenly made a number of us think that really this is a way of thinking about it in terms of individual, family, home-based, community structures and systems across the life course. So including later life, but certainly going as far as early years. And there'll be copies of this around. This is a sort of template after the break to be working on in relation to groups and to look at in more detail. Because this is really putting in place things like perinatal pathways, clearly being very important. That's great, because we've got a great perinatal service in Southampton, in Hampshire, which Alan Gregoire leads, and has been very involved in the perinatal work nationally. So we started really well. I think it's from then on that we've got to look at how what the other bits that need to be developed. And things like support for attachment, peer support groups, work with children, work with adults, and the different sorts of work that might be relevant to each of these areas. And then what we did really was start to put in place, and you won't see this from the back, but all the bits that are not black are the sorts of things that we thought were available in the area, which might be meeting some of those needs. Having got to that point, we then were in a position where we started thinking, well, what goes in and what goes out? And we've had this debate about tertiary, secondary and primary prevention. Not in great detail, but there is I think when we talk about prevention, quite often we are really thinking about primary prevention. What causes severe, and particularly focusing on mental health problems as well. So it's about causing mental health problems, not about improving well-being. I'll come back to that. And that's I think, an interesting debate. So the more targeted approach, which Isabel was talking about, is how we've been trying to think about what should be in and what should be out. But then there's early intervention, and early intervention actually I think has emerged as an area, particularly primary care that I mentioned, which would seem really important to get in there. Tertiary, reducing relapse. Well, we'll be debating this, as to whether that's in or out. I think it's certainly going to be in, but nevertheless it does broaden things very much to services and how services are involved and how services offer support to intervention. And it is broadening the map that much more. And what can you do, what can't you do, and where do you focus? What about factors? Well, I think Isabella's talked about some of these in more detail, really, but these are the sorts of factors that we were thinking were going to be key to be trying to address, particularly when we start to think about measures, and also a bit about then some understanding about the way that epidemiology, genetics, environments are relevant. We're not thinking much about genetics, but we may do something about the environments, clearly. But also we may be thinking more about sort of preemptive interventions. What can we put in place which, and this is a secondary prevention, but what can we put in place that might have an effect further down the line? So this would be with kids, but also an area that we certainly felt we were seeing a real gap is in relation to sort of general stress and how that's managed, because a lot of the working in psychosis area particularly, the more you talk about early intervention, the more you go back to saying actually what we're dealing with is anxiety and depression and sort of broad stress. And that's where this all starts. And then it may be misinterpretations of that lead to delusions. It may be extreme stresses that are leading to hallucinations. But actually we're talking about almost a core stress problem. And similarly with borderline personality disorder, with chronic persistent trauma, early trauma. Similarly with anxiety and depression, clearly, you're starting off at a level where, are there generic interventions really that we look at using at an earlier stage? And that has been a bit of work that we felt is quite important, in Southampton at least, is how do you actually get in early when people are developing problems? Not so much as children, because the project is actually for adults, but I think a lot of the principles are there for children. We were asked to do something in terms of mental health private care, and we were offered 50,000 to start with, and then offered 120,000. Things don't happen like this very often, so when that happens, we try to think, well, how do we use this money across an area most effectively? And what evidence is there out there that actually there are interventions that help with that, and help in primary care in Southampton now as well, because a lot of things have been changing since a lot of this research was done. So there's research on problem solving, research on social work in primary care, which is all quite old. There's also research on collaborative care, which is very interesting. It's really about face-to-face contact, then with a lot of sort of follow-up, telephone call follow-ups. in place. And it's been shown in the US to be quite effective. In the UK, certainly some evidence of effectiveness. But we also have IAP now. And IAP was not in place when the UK studies of collaborative care were being looked at. So there's working out what's going to work. And what we came up with was actually something which was based on problem solving, using a problem solving instrument and connecting to resources. We have 3 band 4s working in hubs. We have a band 6 community nurse as well, working alongside them. Actually picking up the sorts of problems that start quite early. So this is the problem solving instrument that's used. It's looking at key areas in people's lives, nature and so forth. Sort of problems presenting are really lifestyle problems. And we feel if we can get in with some of these, we might be able to help stop things down the line. So we had somebody who come in who had a termination, hadn't talked about it, did talk about it with the worker, was linked up with pregnancy advisory service, who have offered us support. Somebody who'd been diasored, who'd been intimidated by his father, who was still living at home, needs some confidence to move out, and also some direction. So some simple problem solving has helped these individuals. And there's quite a lot of other sorts of that's one lad with on the autistic spectrum who couldn't cope with cancer, just couldn't cope with the first infection. He was quite distressed. But then he found out that email counselling was available apparently through Relate. So immediately we managed to work that out, work that out. So the simple problem solving supports really were quite interesting and do seem to have a role at this stage. So I think there is an area around primary care counselling that we need to be working with in relation to a key part of this overall plan. Early intervention. This primary care is where people are coming with minor emotional and early emotional needs. We get right at the heart of that, what it will be, as well as working with children and other areas. And then there are other initiatives that can improve emotional well-being, and the university we've been talking about these. But how much should we be focusing on these to try to prevent and target people's severe mental health problems? My feeling is probably not a lot of them. Outside what we can do as a group. Now, I was not saying society should, but as a sort of mentally healthy Southampton program. At the moment, our feeling is probably things like clean air. They do seem to be important in terms of children's mental health, but that feels a little bit beyond what we as a group can handle. But again, interesting, and therefore not within the plan that we're looking at. But again, that's a debate. Okay, so that's the plan. What's in, what's out, we've been working out what's in mean. I think the other thing then, the next thing really is then to be thinking about, but when you've got different bits and pieces in here, how good is the coverage? So are we reasonably satisfied with individual care for and other care for early years and family formation or not? Are the right elements there? And are they in sufficient quantity? And that's work that we're really doing at the moment. So, health visiting, very important in terms of attachment. Do we have enough health visiting? And how do we find that out? And that's the stage where we've reached. And really, I think our view now is that it's talking with the individual agencies and getting their opinion. It's going to be the routes to start looking. And similarly with each of the other squares. And that's something that's we'll talk about a little bit this afternoon in terms of workshops. Look. Okay, how do we measure change? Well, there is so much data out there, but it's not strung together. And when we started to look at, well, how do you measure things like childhood attachment? How do you measure childhood trauma? There are a lot of amount of proxy measures out there, or actual measures out there, but they don't seem to link together at the moment. And the PhD Physics tool has a lot of this on, and the CHIMAT, the Children and Maternity Observatory, also have a lot of this information. And can we string these together in terms of looking at trauma-based issues, drug-related attachment, and incidence of psychosis? Is what we should do if we're having an effective prevention program, reducing the levels of significant mental health. We've got to be able to measure it properly, and that may seem very ambitious, but actually, in the end, that's what we would be looking at the measures in the longer term, and of course that is longer term. But even some of these things like drug use in teenagers and psychosis, there may only be a year or two between that, or less between those events happening. We're focusing on drug misuse and we did manage to do something about that, and specific purpose use of developed legal highs with recently in candidates. So we might see quite early gains. So just to sort of finish really, as we've been developing the STAR project, we've also been looking at resources as well as through the group. I think what we've been struck by is just how much resources we have, and that's not where we came from. I think what we've found is there are just so many people in organisations wanting to offer support and help, and groups that are half full or haven't got enough people to run. That being able to link people through with them is actually something which we feel is a very positive and not a costly exercise to do, which is about organisation. Yes, there are also key issues about resources being removed, and removal of social care resources, safeguarding resources, is clearly going to have an impact down the line. So I also feel that putting this data in place is an incredibly important safety measure for a lot of the things that we have in place at the moment. But the resource issue is an interesting one. So what we do in developing a momentum, putting a community together, developing a map, looking at evidence, looking at coverage, looking at protecting and developing, and when we're starting to look at what's changed, we'll come back in a few years' time and talk about that with you. So that's that.